Good evening, and welcome to our Columbia Children's Health webinar, one of many in our series. And tonight, our topic is obesity, an expert review of the 2023 American Academy of Pediatric Guidelines. I'm Jennifer Ratner. I am a pediatrician. I'm going to be your moderator tonight. I'm also the Director of External Affairs for our Department of Pediatrics here at Columbia University Irving Medical Center. I want to welcome our audience of pediatricians and other pediatric healthcare providers. And I want to welcome our panel of experts. And our first expert tonight will be Dr. Jeffrev Baidal, who is a pediatric gastroenterologist and the director of our Pediatric Obesity Initiative. We have Dr. Zitsman, who is a pediatric surgeon and the director of our Center for Adolescent Bariatric Surgery. Dr. John Rausch, who's a pediatrician and a specialist in childhood obesity and weight management. Dr. Ilene Fennoy, an endocrinologist, a pediatric endocrinologist, and a specialist in nutrition and obesity medicine. And Dr. Lleana Vargas-Rodriguez, who is a pediatric endocrinologist as well, and a specialist in childhood and adolescent diabetes and obesity, and also a specialist in culinary medicine. And I hope we get to talk a bit about that as well tonight. A couple of housekeeping items. The chat has been disabled tonight, but the Q&A is open and we welcome your questions. And I hope that we can get to as many as possible, either at the conclusion or some of our experts will be able to type in the answers during the webinar. This slide is a reminder to follow us, Columbia Children's Health on Facebook and at Kids at Columbia on Twitter and on Instagram, where we have a lot of really interesting content that I think our audience would really appreciate. And also this slide is a reminder of our disclaimer that webinar content should never be used as a substitute for direct medical advice from a physician or another qualified health care provider or clinician, or this webinar should not be used to treat your individual patients specifically. This is a more general webinar. And I also want a little reminder that you can watch this, rewatch this webinar starting tomorrow on our YouTube channel. And a reminder, we will also send out a follow-up email because we will be talking about resources that are available and some phone numbers, et cetera. And we will send up a follow-up email with all of that information. And just a plug for our spring webinar, which will be coming soon. The date will be announced and it will be, tentative topic is spring and beyond allergies. So we'll have a lot of really nice information on that. And with that, I turn to tonight's webinar and the topic, which are the new AAP guidelines. We were welcomed in January with these practice-changing guidelines. Very exciting. They were based on, I think, over 16,000 studies, evidence-backed studies. And I hope tonight that we talk about everything from how obesity is influenced by the social determinants of health, talk a little bit about speaking about obesity in a non-stigmatizing way with your patients and families. And of course, we will try to unpack everything from the evaluation and steps to take when talking to families and patients to the three main treatment buckets, which are lifestyle, medication, and for select patients, bariatric surgery. But all of this with the real goal of supporting our children and adolescents in our clinics and in our offices, and how to really implement these guidelines in a meaningful way and in the right way. So with that, I will start the discussion. And I will first turn to Dr. Rausch to talk about, in the pediatric primary care setting, what do these guidelines say about screening and diagnosis? What are we supposed to do? What has changed? What's different from prior recommendations? So with that, I turn to Dr. Rausch to start the discussion.
Thank you so much, Dr. Ratner, and I'm thrilled to be here, and I'm thrilled to see that so many people are on the webinar tonight. Can we have that first slide up? So this is the overall algorithm, which is not part of the actual guidelines, but one of the many things that are on the website as additional tools for providers that are available. And the algorithm is great. So, and we will have links to this at the end of the webinar. In terms of screening, we should, and the AAP still recommends that we use BMI percentile. So this requires measuring height and weight, calculating BMI, and using the age and sex-specific CDC growth charts. One change from the previous is that we now have the extended BMI growth charts, and I'll mention how we diagnose severe obesity in 1 minute. And this should be done at least annually, but pretty typically at every child visit. I know that BMI percentile is not a perfect measure and that there is some controversy regarding this. There are better measures of actual adiposity, but it is definitely the least invasive and a very easy measure to use in the office. And so for that reason, it is still recommended. And for the most part, is pretty sensitive and specific for BMI comorbidities. I did want to mention that as we're talking about screening our children, I think one of the most important points is that we do it, again, in a non-stigmatizing way. And again, this is very much emphasized throughout these clinical practice guidelines. And so, for example, when you're screening, what I like to do, and this is recommended in the guidelines, is that we ask permission to do this. Is it okay that we talk about this? And I think that really opens up the conversation and lets the patient take control in some ways of the conversation. And for the most part, I found that to be very helpful. In terms of diagnosis, the way in which we diagnose overweight and obesity has not changed. It is still 85th percentile for overweight and 95th percentile for obesity. In terms of severe obesity, the way in which we diagnose actually has changed. So in the last guidelines, it was the 99th percentile was considered severe obesity. Now we use percentage above the 95th percentile. And severe obesity is 120th percent of the 95th percentile. So that is one big change from the last guidelines.
Great, excellent. Thanks so much for that. And then in terms of further evaluation, once children are diagnosed with either overweight or obesity, I think that what is very new are the evaluation and the lab evaluation. And for that, I want to turn to Dr. Fennoy to discuss that lab evaluation and other screenings that need to be done. So, Dr. Fennoy.
There we go. Thank you, Dr. Ratner. Good evening. The new guidelines divide children not only by weight, but also by age in terms of our approach to evaluating them with respect to laboratory testing. But the basic things that you do all the time in your practices, the comprehensive history, the mental behavioral health screening, the social determinants of health, physical examination, diagnostic studies, and blood pressure are present for everybody at all ages, irrespective of their weight category. Once we get to children over 10 with overweight or obesity, we're interested in getting a fasting lipid panel. Fasting lipid panels are most important for triglyceride values. Random cholesterols can be reasonably close, but in this situation with children with weight problems, it is important to begin to look at triglycerides as well as cholesterol, and for that, a fasting lipid panel is best. For children less than 10, the AAP guidelines are only recommending that you do fasting lipid panels if they are frankly classified as obese. In terms of other laboratory testing, by and large, it's for the children who are over age 10 who are classified as obese. and include tests like fasting plasma glucose, oral glucose tolerance tests, or hemoglobin A1C, and the ALT. The OGTT that's recommended is a 2-hour glucose tolerance test, and it's really OGTT or fasting plasma glucose. It's not that you have to do an OGTT. The two aspects of the glucose tolerance test is the fasting value and the 2-hour value. The 2-hour value does give you some information different from a fasting value, but it may be difficult to get families to get it done properly. And hemoglobin A1C, as well as fasting plasma glucose, are considered appropriate tests to do without having to do an oral glucose tolerance test. We are also recommending ALT now. For children who are in the overweight category, risk factors need to be assessed from your history as to whether or not you need to gather any of these laboratory testing. And then in the event of abnormal labs, then you may proceed on to further testing, or just repetition of the testing after a certain period of time when you have done some intervention in terms of helping them to deal better with their weight. For elevated blood pressures, there's the goal of looking at your hypertensive blood pressure guidelines to determine what you wish to do next. But again, elevated blood pressure by definition requires multiple measures, not one single elevated blood pressure. So there's an opportunity to have several interventions or several interactions with your patients and family before moving forward with further evaluation on that issue.
Great. And I think it's helpful to have the AAP's algorithm up here as well. I just wanted to circle back on a couple of points you made, Dr. Fennoy. Maybe either you or one of the other physicians might want to just answer about specific risk factors that you do talk about with patients and families, from their family history, and then a little bit about the abnormal labs and who you might refer to after that. What are some, real red flags in the labs? So maybe Dr. Vargas-Rodriguez wants to address some of those points.
Yes. Well, I'm a diabetologist, so I take care of children who have prediabetes and diabetes. And when we look at the hemoglobin A1C, for instance, a normal hemoglobin A1C in most adolescents is somewhere between 4.9 and 5.2. So when we get an A1C, if it's less than 5.7, it's considered normal, and between 5.7 and 6.4 is considered prediabetes, and above 6.5 is considered diabetes. And so it's really important that we pick up children quite early. So I'm going to focus a little bit on the diabetes. And I just got this little endocrine news article that said the percentage of US youth ages 12 to 19 living with prediabetes has actually more than doubled in the last 20 years. And it's actually 28% of our children. And so it's really important that we obtain a fasting blood sugar if we can, and a hemoglobin A1C. As far as lipid levels, the way I teach my patients and their families is we want the HDL level to be greater than 40. And I call that the HDL as a healthy cholesterol, and the LDL, or the lousy cholesterol, ideally we want it to be less than 100. And so, and the liver enzymes, and this is where I think Dr. Baidal can talk a little bit more about, we're seeing a lot more fatty liver disease, unfortunately, in young children also.
Yeah, thank you. I think, I'm a pediatric gastroenterologist, and I think one of the kind of big points I want to highlight is that the guidelines really are asking us to remember that obesity is a complex chronic disease. It's highly prevalent, and it really requires a whole child evaluation. And when we identify potential comorbidities, it does require evaluating and treating those comorbidities. And so I bring this up because since obesity is so prevalent, it is also possible to have other, underlying problems such as autoimmune hepatitis or some sort of metabolic, liver disease. And so it's important that if the ALT is elevated, it's usually twofold above the upper limit, which unfortunately upper limits in different labs can be variable. So I usually use above 50. If it's elevated on more than 2 occasions, a patient really does deserve a referral to a liver specialist to have a complete evaluation, not just for kind of the grading and staging of fatty liver disease, but also to consider whether some other underlying liver disease may be present.
One of the other issues is when we're doing all the history taking with our patients, we need to be particularly sensitive to family histories because many of these medical problems run in the family. And there are numerous studies that demonstrate if the family history is positive, like if first-degree relatives, parents, have type 2 diabetes, the likelihood that the child will get type 2 diabetes is much greater than if no first-degree relatives have diabetes. The same is true for cholesterol and lipid issues. People who die young from heart attacks, less than 50, the odds are that there is a lipid problem in the family and it needs to be addressed. And obesity will only bring this out or make it worse. So this is an excellent opportunity to delve more deeply into your family histories and see if there are metabolic medical problems that we should be addressing, or if the child is beginning to develop them themselves. The other issue that you need to be aware of is as children age, particularly as they go through puberty, blood sugars and insulins increase. That is a normal pubertal event. However, they still have to be within certain normal ranges. So a fasting blood sugar greater than 125 is a diabetic blood sugar. A 2-hour blood sugar greater than 200 or a random blood sugar greater than 200 is a diabetic blood sugar. 100 to 125 for fasting is impaired fasting blood sugar, which is a pre-diabetic state. And 140 to 200 at 2 hours is, again, a pre-diabetic state. So you have to really look at these values because these children are demonstrating once they have prediabetes that they're at increased risk. If they have elevated lipids, at increased risk, and they need referral to endocrine, cardiology, GI, if it's ALTs, for further evaluation.
Also, Dr. Ratner, to answer touch on the other question you asked, I think some of the things that we tend to ask about are about headaches, because what some people call pseudotumor or increased intracranial hypertension is another potential complication. Also, bone and joint problems, thinking about SCFE. Also, asking about symptoms related to sleep apnea, snoring, daytime somnolence. So again, and then of course, mental health. So, obesity among children and adolescents is linked to a number of short and long-term health complications. And we know that there's a lot of stigma and bullying that can happen, and understanding in a sensitive way, whether there's risk for depression or other mental health problems, and providing the appropriate resources is also really important.
One of the most unrecognized bony issues is osteoarthritis. Osteoarthritis of the knee definitely is occurring in adolescent children with severe obesity. And so when they're complaining of knee pain, getting evaluation may be important, and it also changes your feeling about how much intervention you may need, because the continued high weight is only going to aggravate the osteoarthritis.
So I think those are all great, excellent points, and I really, really appreciate it. And I see we have some questions in the Q&A about some other labs and evaluation, but I'm going to move on a little bit. So we've done the evaluation, we've covered some of the comorbidities, the labs, et cetera. And then I want to delve into the sort of 3 buckets of treatment. The first being this intensive lifestyle health behavior treatment, and this magic number of 26 hours that a lot of people have been talking about. And I'm going to turn to Dr. Wu Baidal to talk about that, especially because it's important, because as we move on into the other 2 buckets, medication and surgery, this is a constant. So if you could just start talking about that a little bit and how we can use this in our practice.
Thanks, Dr. Ratner. I think we have a slide on the treatment that we could put up. Thank you. I mean, I think one thing I do like about this part of the algorithm as well is that it, again, underscores the need to treat the underlying comorbidities and to provide treatment in the context of the medical home using a chronic care model, which basically means, we need to follow patients over time and using family-centered, non-stigmatizing approach. And again, just reminding us, it's a whole child evaluation. We have to consider, part of the evaluation is understanding the social and environmental context and really being sensitive to the structural inequities that exist. Because I think that's really important it plays a role in providing treatment. And so I know we're talking about 3 buckets, but I really think it's 4 buckets. And I want to also send kind of a key takeaway, the big change with these guidelines from the prior kind of expert committee recommendations is that there's no more role for watchful waiting. So really it's intervening immediately upon diagnosis in intense of a way as is possible. And so one of the things that we all can use is motivational interviewing, which is, one of the most evidence-based intervention, or one of the interventions that has the most evidence behind it when it comes to behavior change. And, it uses techniques to identify the motivation and the priorities of the family. And that plays into this 26 contact hours and what's, going to happen during that time. So I know we'll provide some resources on motivational interviewing afterwards, but I wanted to underscore that it really is, it's hard to do. I think it's hard to use. I'm always trying to learn more about it and practice and beating myself up about not using my open-ended questions and reflecting back. But I think it's worth practicing because, again, there's a mountain of evidence behind it. When it comes to the IHBLT intensive programming, the focus there really is on, healthy eating and nutrition, really in developing sustainable patterns, not using very low or very restricted diets, and then focusing on other things like physical activity and other behavior change, healthy sleep promotion. And at this point in time, it's not clear that one particular focus of behavior change is necessarily more important than another. Probably understanding those priorities from a family is most important. And it seems like contacts in group, individual, in person or virtual, all could be done and most likely would be effective, although the data on using virtual or virtual groups is less robust, just because I think it hasn't been as studied at this point in time, and we'll learn more down the line. But I think 26 contact hours in 3 to 12 months sounds really daunting. I think the point is, do what you can with what you have available. It does not need to happen in your practice. You can collaborate with community groups. And we know that this information or this type of programming is not widely available. And there have been some really large moves from CDC, I think AAP, and I think these guidelines are serving as a potential lever to help shift the burden, from providers trying to figure it out on their own to payers and policymakers to figure out how they could provide coverage for this evidence-based, safe and effective treatment.
That's great and really, really helpful. And I hope we can address some more of these issues towards the end of this hour. But I want to move into sort of the second of the four buckets, as you pointed out, or the third of the four buckets, which is we've heard a lot about the guidelines being very different because of the recommendations for medication for some children and adolescents with obesity. And what do pediatricians really need to know? What are these medications? Some of the experts on this panel have probably the most experience of any of us, or maybe any of us in the nation, using some of these medications. I know one of these medications was coincident, right when the guidelines came out, there was a new approval for a new medication. And I think maybe Dr. Vargas-Rodriguez can address this question the best, since she has a lot of experience with medications in children and adolescents.
So before I talk about medications, I just wanted to bring a couple of points. Dr. Fennoy mentioned insulin resistance of puberty. So during puberty, as kids are growing and they're making growth hormone, they become more insulin resistant, and insulin resistance increases by 30 to 50%. On top of that, if you're living in an environment where there's food insecurity or there's a lot of stress in the home, you make something called a cortisol level that can also make you more insulin resistant. So all these things can push you over the edge. And understanding what's going on in their home where the child lives, what kinds of foods are available for them, is extremely important. So as far as medications, unfortunately, metformin is one of the ones that I use the most, and it's FDA approved in children greater than 10 years of age. In children who have diabetes, we've had a lot of experience. And here at the Diabetes Center, we were part of the original clinical trials. One of the problems with metformin is that it can give you diarrhea and upset stomach. So with many of my patients, I start at a low dose, and I usually start it on a Friday night, because what we found in the studies, if kids need to poop in school, they're definitely not going to take the medication. And it's better to go slow. But I can tell you that in patients who have diabetes and are really adherent to the medication, as far as lifestyle medication modifications also, their A1C levels can decrease as much as 1 to 2 percentage points. As far as pediatricians are concerned, it's only FDA approved in children who have diabetes, although off-label and in adults, it's been FDA approved in prevention of diabetes and using it in prediabetes. And I saw there was a question on polycystic ovarian syndrome. And yes, 1 in 8 females has polycystic ovarian syndrome. And there's some very good studies that show that you can use metformin in this condition to help regulate menstrual periods and to decrease the insulin resistance and their risk of developing type 2 diabetes. So I feel pediatricians need to become comfortable with metformin. It's FDA approved, and it comes in a liquid form. It comes in 500 milligrams and 5 mLs. And if you have children with a strong family history of type 2 diabetes, a child whose mom had gestational diabetes, and a child who has prediabetes, eventually, if we have 28% of the population, they can't all come to endocrine. They need to also be seen by the pediatricians, and we want them to get comfortable. Also, children who have, that we didn't even touch on, children who have autism, who are on the spectrum and are given medications for their behavior. Some of the medication, like risperidone, can actually increase their appetite. And many of these children then go from prediabetes to diabetes. And there's some studies that show if you start metformin at the same time that you start these medications, you can actually prevent weight gain. The medication that everybody wants to hear about is the GLP-1 agonist. So in endocrine or in diabetes, we've been lucky because we've been using this medication since 2019 when it got FDA approved for the treatment of diabetes. The medication that was used was the daily laryngotide. One of the issues with this medication, it's a great medication, and the way we have to kind of step back when we eat, the food goes to our intestines, and our L cells in the intestine make something called GLP-1, which then tells our brain that we've had enough to eat. So by giving GLP-1 medication, you're actually decreasing the child's appetite. And when we first started this medication in 2019 in the children with diabetes, we had some kids who were on insulin and whose A1Cs were 8 and 9, and they came down to 5.8, 5.2, and they're off insulin. One of the things that we need to keep in mind is that medications are long-term. If you have hypertension and you're treated for hypertension, your blood pressure goes down, doesn't mean you stop the medication. So one of the things that we're going to have to learn is that these medications may be a lifelong treatment for many of the children who carry excess weight. I really don't like using the word obesity, and many parents do not like that word either. They'd rather you say excess weight and not really call their child obese. So we have to be very sensitive with that. I just want to make sure, anything else, Ilene, that I should say about medications? We also have other medications. Orlistat is approved, and there's actually, it's a lipase inhibitor. Again, it makes children poop, and most of them do not take it. And in fact, most of us in this panel probably not utilizing that medication. Phentermine is approved in, which is basically, it's a stimulant, along with topiramate, is also used, and I do use it in some of the patients who have excess weight, but maybe Ilene can help me with this a little bit, because they're not FDA, well, they're FDA approved now for over 16 in children, but it's not a medication that I personally use too much. I use more GLP-1 agonist, and so it's sold under Wegovy, and it starts at a very low dose of 0.25, and you can go up to 2.4. I can tell you from experience, most of the patients only need about 0.5 to 1 milligram. You don't even have to go to 2.4, and you can get a significant weight loss, like 5 to 10% of their total body weight. But and I tell this to my patients, once you make a fat cell, it's yours to keep. When you lose weight, the fat cell shrinks, your leptin levels go down. It then sends a signal to your brain, and you make something called ghrelin that makes you hungry again, and you can regain the weight. And so again, these medications are long-term.
Just adding about the phentermine and Topamax, it has been recently approved as well for down to age 12 as a combination medication. But one of the issues with all of the medications is understanding their side effect profile. And the phentermine Topamax combination has issues about phentermine raising blood pressure, Topamax possibly causing forgetfulness. These are all issues that may be problematic in any one child. The GLP-1 agonists have been particularly liked by those of us in the endocrine community because they have such a positive effect on most of your cardiovascular risk market. So lipids go down, blood pressure is neutral or goes down. So these are, as well as you lose weight, glucose and insulin improve. And it's hard to find a medication that has so many improvements on the common abnormalities seen with the increased weight. So we tend to like it a great deal.
I agree. I call it a game changer. It
Yes.
really has improved the life of many of my patients.
So I think thank you so much for that, doctors. And before we move on, I just wanted to ask, perhaps maybe Dr. Rausch can even answer this. But so it seems like in the foreseeable future, people with experience like endocrinologists will be the ones prescribing these medications. And then in the little bit longer term, as we learn and become, as pediatricians, more comfortable with the medications, which are right for particular children, and what the side effect profiles are, we will be taking that over more and more. Everybody seems to be agreeing. I think you're.
Yeah, yes, absolutely. I think this is something that, I mean, it's akin to depression or akin to ADHD. There's certainly just not enough specialists, and certainly with obesity being the most prominent chronic condition in children, there's no way that we're going to ever have enough specialists to treat this. And so I think one of the most important things is really getting insurance companies to pay for these medications so that we can actually start using them. And getting comfortable with them. And I think advocacy for that is very important. But I ultimately see this as a problem that definitely pediatricians are going to take classes in and get comfortable with and start prescribing in their practices. And really for those really chronic and kids who have severe obesity, those are the kids that may be going on to the weight management programs. But I think with this new impetus to start treatment early, I think it's going to be really critical that it happens at a fairly young age and in the pediatrician's office.
And we'll provide some of those resources at the end for classes and how pediatricians can also become more formally trained in some of these medications. And I don't want to miss, because I see time and we have a lot of questions, moving on to the third or fourth bucket of treatment in severe situations for children with excess weight, to talk to Dr. Zitsman, something pediatricians will never be doing, which is talking about bariatric surgery, and who are those children that we will refer to a center like Dr. Zitsman's. How do we approach that talk with the families, and what can we tell the families and the children about what will happen when they are referred to you and your colleagues?
Thank you, Dr. Radner, and thank you for including a surgeon on this panel. I think that if we look at the history of the AAP and how they've addressed obesity over the past 23 years, the AAP guidelines have gone from not mentioning obesity to discussing obesity as a problem to be dealt with expectancy or with diet and exercise, to then addressing it to a disease as the AMA defined it and realizing that it needs treatment. There are previous guidelines in 2014 reached the point of saying that surgery was a consideration for severe obesity. And now the latest guidelines in 2019 say that surgery, metabolic and bariatric surgery, has a definite role in children and adolescents who have obesity. I think there are a couple of concepts that might be helpful. When we think about surgery, or when many people think about surgery in terms of obesity, it's at the end of the line and it suggests failure. And again, we want to be sensitive to the language. So this is not failure, just as in your practices, you have patients who have mild asthma and you have patients who have severe asthma. And the treatment is going to vary depending upon what they have. The disease itself, obesity, accelerates the aging process. Younger people get older faster. And there's much evidence to suggest that. When you think about it, those of you who have been in practice for decades, when you were first in practice, you probably didn't really have to deal very much with patients who had fatty liver disease or who had hypertension or cholesterol problems. Those were diseases that their grandparents had. And now we've sped things up so that the diseases that you're seeing are the diseases that are consequences of this chronic condition. And so in managing it, it's important to think about escalating care. So for someone who has mild to moderate obesity, then behavior management, diet, exercise, lifestyle behavior is an essential place to start. For people who have more severe obesity, who may be pre-diabetic, who may have elevated blood pressures without hypertension, they're not on medications. They may have enlarged livers, things like that, then these medications that we're talking about have a definite role. But for somebody who comes in with a BMI of 55, who has any number of the problems that we have, the likelihood that she or he or they are going to lose enough weight to correct those problems and have them go into remission. And I always argue with my colleagues who talk about curing diabetes and curing hypertension. You don't. You can send them into remission, much like HIV. You can turn it from a fatal disease into a chronic disease that requires lifetime management. And so that's where surgery comes in. Surgery has a role in patients who have severe disease and highly selected, highly screened patients who have disease, because surgery doesn't make them lose weight. Surgery makes it easier to make the changes they need to make in order to lose weight.
One of the things that I have often said to my patients that I work with Dr. Zitsman is that you have to still do the lifestyle, okay? You're not going to lose weight simply by going to surgery, because that'll be very temporary and it will come right back. You really have to embrace the idea that you want to make the changes. And with the surgery, the changes that you've been trying to make now have a big impact, but you have to still make the changes. Many patients are not ready for that. And then surgery is not appropriate if the patient doesn't want to make the changes.
I think Dr. Fennoy makes a very important point, because we as clinicians who are taking care of these patients have a tendency to focus on what's abnormal about the labs, what's abnormal about this and that. But the single greatest motivating factor that I've encountered in more than 15 years of doing this is that these kids just want to be like their peers. They want to dress the same. They want to be able to sit in the movie theater. They just want more normal lives. And that's an enormous motivator that we can lock into to help them.
And I think that point also holds true for medication. Like, there's no evidence for using medication as a monotherapy. And I think what I've learned, working with Dr. Fennoy and Dr. Zitsman and everyone else on this panel, is there's just not like a single one tool that fits everybody. And the treatment options that work at one time, may change over time, and you may have to add or go back to things later on. And I think, like Dr. Zitsman said, it's not a failure. This is a very complicated disease with, intense biological underpinnings. And it's a lot of work to understand and to get the treatment right.
I had the opportunity to speak with someone earlier today who actually is attending the seminar. And I said, think of it like something that you're doing at home, some construction project that you might have some tools, you might, be able to do something simple, but then you realize that actually maybe you have to go get a power tool to do this. But there's some things for which, at least for me, they're over my head, and I need a carpenter or cabinet maker or somebody who has yet further skills than what I do. And that's what these different modalities combine. But just because you have a carpenter doesn't mean that person is not going to be using the same tools that you were using before.
So excellent answers, and I really appreciate everyone chiming in. I think we've gone through a lot of the main points of the algorithm, and there are a lot of things to circle back to. A lot of the questions that are in the Q&A are really excellent. Some we've touched on, some we have not, and we're going to try to get to those in the next few minutes. One really excellent question is, how can school nurses work in partnership with pediatricians and families? That food, and the questioner points out that food insecurity often pairs with school food choices. This question also wants us to address recess and physical education time symptoms that are brought to the school nurse, like knee pain, headaches, body image feelings, and how can we as communities work better together. I don't know who wants to take this first. I see a lot of nodding. I know that Dr. Rausch has a lot of experience working possibly with schools, or a lot of our clinicians do a lot of work in the schools. Anyone want to take a first stab at this answer?
Well, I've worked on getting universal free lunch here in New York City, and I'm actually going to testify on March 15 in City Hall again to try to get it for the state. A lot of people say that school lunches aren't great, but if kids skip breakfast and they skip lunch, what are they going to eat? I mean, just think about the school here in Washington Heights. What do they have? They have Popeyes, they have McDonald's, they have pizza, they have the churro lady in the corner. So school lunches, and the new studies show that if kids eat the school lunches, they actually do better. Now, some schools, we shouldn't be having cake sales, and we shouldn't be administering sugar sweetened beverages. This is my little sugar tube. Let me see if you could see it. But this is how much sugar is in a can of soda. And when I show these to medical students and residents, and even some doctors that come by, they open their eyes. And if we're shocked as doctors, sugar sweetened beverages have the most research. And in fact, if we can get sugar sweetened beverages out of the school, if we can try to show kids how to drink infused water. I work with nutrition education and the kids, and a lot of kids have not been exposed to certain foods because, first of all, maybe the parents can't afford it, and two, if you are working 2 jobs and you come home, you're not going to try to, grill some broccoli and do this, and then the kids don't want to eat it. So it's a real problem. But just cooking at home and eating real food, white rice didn't get us here. Pasta didn't get us here. And so, saying to have brown rice, no, I'm of Puerto Rican descent. I want my white rice. I'm going to have a small amount of rice with a mountain of beans. If you're Italian, you want to have your pasta, but maybe throw some vegetables in and some tasty food. And that's what culinary medicine is. It's about food as medicine, getting people to rethink why they eat. A lot of us, we just don't understand that if we have a bacon, egg, and cheese for breakfast, pizza for lunch, McDonald's for dinner, what vitamins and minerals that we get into our diet. So I teach the kids a lot of counter marketing skills. And I tell the kids, the food industry, what do they care about? And they all know, and they all say money. I want everybody else to chime in, but it's really important that we are open with our patients and telling them that the food industry is targeting our children. And it's basically telling us that you're not a good mom if you don't give them junk food. I know that Dr. Fennoy and Dr. Baidal and John have a lot more to say about that.
I would just say, that schools are a critical place, just as they are for asthma, for example. If we don't send our kids with their medication administration form, they can't get their medications in school, right? And so schools are where kids are spending a heck of a lot of their days and their lives, right? So schools are certainly critical. And I've worked on a number of programs that recognize this and really work to improve the school environment. And that includes the school nurse. It includes the gym teacher. It includes trying to get more physical activity for our kids, which we know none of our kids are meeting the recommendations and standards that are set out for physical activity right now. So whether that's transitional exercises between class, whether that's having our nurses, whether that's getting our parent groups to choose the healthier lunch options and do that as a school, there's so many ways that we can work with schools. And I think as pediatricians, we're perfectly situated as advocates for kids, and we have a lot of connections with schools. So I think talking with the school, getting involved are all really important aspects of dealing with this epidemic.
Actually, the CHOC program does a weekly webinar, which is part of NYP and Columbia, with Cal Murray, one of the dietitians, gives free webinars both for yoga and for food on a weekly basis. So maybe we can add that.
Yeah. So that's really excellent. And especially Dr. Rausch's point about being an advocate, and Dr. Vargas-Rodriguez has been an advocate supreme, I would say, going down to City Hall and testifying. Not all pediatricians on on this webinar can do that. But I think to Dr. Rausch's point, advocating in schools, in local schools, in your local schools is extremely important. And that's what these guidelines have really also set out a lot of points that pediatricians can use to advocate, and a lot of things that we obviously need to advocate for. I don't want to miss an important question that's come up. Many of you have seen this. It came up in on social media when the guidelines were released in January, came up in traditional media discussions about the guidelines. It's come up in discussions between pediatricians, and that's the relationship between encouraging healthy weight or weight loss and then eating disorders. And I thought we cannot ignore this question, and it's an important one. And a number of our questions in the Q&A are about this as well. So I don't know who would like to tackle that first. Maybe Dr. Fennoy.
There are a number of studies that have attempted to look at this issue. One of the things that has been found is that children who have obesity have a high frequency of eating disorders to begin with. And successful weight loss is often associated with a decline in eating disorders. So I think we need to be careful about assuming that we're making eating disorders in patients. Most of my patients who have been most concerned about it did not have obesity as their problem. They had a sudden weight gain of a small amount that wasn't really a problem, but everybody became very nervous about developing an eating disorder, rather than my patients who had truly a serious weight problem and had an eating disorder that we needed to work with psych, get them involved in cognitive behavioral therapy or other programs to help them deal with their eating disorder.
Yeah.
Excellent.
There was a question on binge eating disorder. I find you have to ask patients. You have to ask them, or ask permission if you can talk about their weight. And if they tell you no, then basically you can say, okay, you're not, I'm going to accept that you don't want to talk about this, but it's really important that we maintain our weight. And weight maintenance is extremely important. And we underestimate it. If a kid stayed the same weight and they're growing into their weight, for every inch they grow, they can lose 5 pounds. And so it's really important if this is happening. Now, if they have a binge eating disorder, definitely you need to work with the psychiatrist. And there are medications that are being utilized for binge eating disorder, like Vyvanse is a very great medication. It's FDA approved for the treatment of binge eating disorders. And I frankly just ask my patients, do you eat a lot at night? And some will buy a lot of food, put it in their backpack, and when their parents go to sleep, they'll eat it all, and their parents will find basically the wrappers the next day.
Well, thank you for that. Being cognizant of time, we have a number of other excellent questions. Some have been answered, I believe, in the Q&A, typing in as well. But we have a couple of summary slides. And as we talk about them, if any of the panelists has just a little pearl that we have not mentioned, whether it's non-stigmatizing language pearl that you might have, to why you think these guidelines are important. You can offer that as we go through in the last 3 or 4 minutes or so of these last, if you could just put up the last 3 slides for us, which are review. I think maybe Dr. Fennoy might just want to quickly go through them.
Yes. Thank you, Dr. Ratner. These are the major components, and I just want to remind everybody that the basics are things you're doing every day. They're not additions to your practice. So the history, mental health, behavioral screening, social determinants of health, physical exam, blood pressure in particular. Diagnostic studies is probably the only big issue here. And that one is primarily associated with those with increased weight, particularly if they're greater than age 10. Okay. Or if they're less than age 10 with risk factors, particularly for diabetes and non-alcoholic fatty liver disease. Other labs that we do are really focused on children older than 10 or children less than 10. That's a mistake there. Children who are less than 10 with overweight and with risk factors for diabetes and non-alcoholic fatty liver disease. So you're really looking at your history to help you determine who to apply these to. You're looking at your BMI, and then it's a limited number of studies, but they do require some fasting studies.
Excellent. And then the next slide.
And always, our lifestyle is the basis of all obesity interventions. Nothing works without the lifestyle intervention. So pharmacotherapy is an addition to the patient who's doing lifestyle and getting nowhere. The same for bariatric surgery. There are the additional guidelines about how extreme you have to be for each and what age, but basically the motivational interviewing and the lifestyle behavior modifications are really what you want to do. And we're starting as young as age 6 if they're overweight or obese, and younger than age 6 if there are risk factors for diabetes or non-alcoholic fatty liver disease.
And it's also just, this slide is just pointing to the treatment of comorbidities as being important as well. And then the next slide, just before we conclude, this slide has a large list of resources with links that we are going to send out, all of these links to you in a follow-up email if you signed up for this webinar. And they are really, really excellent. And it's going to include a few more that we mentioned tonight. I know there were a lot of questions about motivational interviewing. This will have links to some motivational interviewing practice. Some are from the AAP, some not. There's also will be a link to a Columbia and Cornell course that's coming up in May, an obesity course, a CME course. And we'll have a link to this AAP practice guideline algorithm, which has been a little hard for some people to find as it's a little bit separate on the AAP website from the guidelines themselves, but it's really excellent. We excerpted from that during this webinar. It will have a link to a really nice culinary medicine website. And I think you'll all pediatric practice providers are going to find these links really, really helpful. I know I have found them extremely helpful. Many of them I did not know about. And then on the right, and we'll provide this as well, are phone numbers to all of the locations where our providers and our panelists tonight actually work, and direct lines to their offices, which I think is a nice resource to have all in one place. I want to thank our panelists for really delving into these practice changing, extremely important guidelines, and making them, I hope, a bit less complicated for all of you who are in our audience tonight. And I thank you all for listening. I remind you that if you missed some of it or you want to recommend this webinar to people who missed it tonight, it will be up on our YouTube channel by the end of this week. Our Kids at Columbia YouTube channel. Don't forget to follow us on social media, especially on Instagram and Twitter. And don't forget to look out for our spring webinar, which is promises to be a lot of topics that will be useful, I hope, and informational for all of you. Thank you so much again, and good evening. And thanks again to our great expert panelists. Really appreciate your time. Good night.
Night, everybody.
Right.
Night.